So again, thank you to the faculty for inviting me, and a special thank you to Rita, my friend. And I'm very happy and I'm very honored to be here in my office in London, but to join you in this meeting to talk briefly about optic pathway glioma and when we should treat them and when perhaps we should not treat them. So I have no disclosure other than I'm not an ophthalmologist, but thanks to my mentor, which I'm sure you know, which is Giorgio Perilongo, I started realizing the importance and perhaps learn a little bit of ophthalmology, which is key to understand this disease. So low-grade glioma of the optic pathways represent a benign tumor, but affecting some functionally critical structure and occurring in us up to a quarter of children with low-grade glioma. So it's a quite frequent sites of involvement. Similarly to most of other low-grade glioma, molecularly they are driven by similar MAP kinase alteration, as Rita has well pointed out. And in 30% of the cases, optic pathway glioma occur in children with neurofibromatosis type 1. Radiological features of optic pathway glioma can be classified according to very old classification, separating optic nerve from optic chiasm or post-optic chiasm involvement, or more modern classification as the Planck classification, which attempts to correlate the anatomical with the function of the optic pathway. And tumor can range from isolated optic nerve in tumor, you can see on these MRIs, which often carry very indolent behavior, especially in the NF1 population, and they have limited risk for visual loss, mostly in one eye, but sometimes they still can cause a huge tumor in the optic nerve, and in those cases, the visual prognosis for that optic eye is quite unfavorable. But they can present also as a huge and large hypothalamic chiasmatic lesion, which are highly problematic and causing many symptoms, including severe visual impairment, as well as endocrine symptoms and diencephalic syndrome. And these, of course, occur more often in the very young kids. So now, why is not as simple as other oncologic disease? Perhaps because sometimes we miss to capture and understand the difference between the short and the long-term perspective in this disease. So Shofty and all has graphed this very nice example on how the difference between the normal perspective that we often have with this disease, where patients respond to treatment and they fare reasonably well with the chemotherapy strategy, compared to the more unfavorable long-term outcome perspective, where the tumor might start growing back or growing with time and ultimately cause significant visual loss over time. And so while most of the children have a favorable outcome, on the long term, they basically suffer of a chronic disease with accumulating morbidity over time. And ophthalmologists are often the first professional to meet these patients, and they often have a lot of questions around this. So how to best assess vision in these children, and what is the risk of further visual loss, and whether the treatment is needed or not, and if the treatment is needed, when should I recommend starting treatment, and which treatment should it be? And normally the most common answer I see is ask to my neuro-oncology colleagues. However, even amongst neuro-oncology, the decision about when to start a treatment in a patient with OPG is not as simple as reading a book, and is not as simple as reading through the recommendation from the current LGG SIO protocol, which include the presence of severe symptoms, threat to vision, and or a documented clinical or radiological progression. So while it's important to highlight that a postoperative residue is not a criteria to start a treatment, in real life, this needs to take into account all other factors that might interplay and might affect ultimately the risk of progression and the risk for vision. So I would like to present a clinical scenario. So a female, a 5-year-old girl with a clinical and genetic diagnosis of NF1 who presented with very mild visual symptoms, mild strabism, and the visual function at baseline was nearly normal with a kind of a 0.1 logmar in both eyes. And you can see here in the MRI showing this very kind of little contrast enhancing a tumor in the left optic chiasm, and this was associated with a normal OCT. So in a patient like this, I imagine that the decision about starting treatment or not, it could be very challenging, but probably most of us will say that this patient does not treatment, at least up front. And we will see at the end of the presentation what will be the follow-up for this patient. What we know is key is to have a proper and standardized visual assessment in these children. And in order to facilitate this, in the upcoming protocol, the LGG Europe trial, we have made specific recommendation on how to assess vision, which units to use, and how to interpret visual changes. And we advise to use monocular best corrected visual acuity as the main surrogate of visual function, and use logmar units, which are the only units which give us a quantitative measure and enable comparison over time, and possibly use teller acuity cards, which are able to provide consistent measure throughout the patient assessment, irrespectively from age. However, we are allowed to use other testing methods if the physician and the ophthalmologist feels that this is the most appropriate for age. So there is a list of different visual acuity testing methods, and some of them are recommended for a specific age. And it's important that as visual acuity may change with different testing methods, we recommend not to switch the methods between the diagnosis and the last follow-up in the same patient. And we attempted to draw some kind of clear-cut indication to start treatment within the context of the LGG clinical trial, which take into account the presence of a unilateral visual deficit that you can see graphed in this patient with a vision of compromised vision in one eye, but the normal vision in the other eye, or a patient with a severely compromised vision in one eye with no light perception and some degree of visual impairment in the other eye, or the documented progression over time, so a decline in the visual acuity of at least 2 lines of logmar, so like from 0.2 logmar to 0.6 logmar, as the main visual related criteria to start treatment in children with OPG. What are not indications to start treatment? So a patient with a near normal or no threat to bilateral vision can be observed without upfront treatment. And other causes of visual loss should be excluded, as a raised intracranial pressure or poor compliance or refractive errors at the visual assessment. And if the ophthalmology is in doubt, we recommend always to retest in 2 weeks' time before recommending starting treatment. It's important to take into account the normal visual development with age, and we know that very young children, they don't have a normal vision as older ones. So it's important to take this into account, as well as it's important to take into account that a stable vision in a very young child might otherwise represent a lack of normal maturation, which we would otherwise expect with a normal visual function. So what about other visual parameters in OPG? Are they useful? Are they reliable enough to be used in the context of a clinical trial? We feel that for now, there is no other visual parameters that can be reliably used in the context of clinical trial, despite we acknowledge that visual fields deficits are frequent and important in the overall outcome of OPG, but they are difficult to assess in young children and not easily quantifiable. Similarly, the role of OCT, which is a new, relatively new technique, which has proven to measure the thickness of the retinal layer and is a marker of visual function, is not always available in all centers and not always feasible in very young children. And there are no data regarding the changes in OCT with treatment. So there are potentially useful parameters, but not at the point of being used in the context of clinical trials. So now, OPG, as we said before, can occur in children with neurofibromatosis, and they occur during the first decade of life, and they can range from isolated optic nerve, often bilateral, but also to widespread tumors along the optic pathways. The incidence of optic nerve in optic pathway glioma in NF1 is around 10% with time, but we know that most of them are basically asymptomatic, and only 1/3 of them will present with some visual symptoms. And amongst those who are symptomatic, only 30 to 50% have progressive visual loss and ultimately need treatment. Whenever they need treatment, vincristine carboplatin is still considered the standard of care with a favorable progression-free survival in comparison with the sporadic OPG. We attempted to identify possible risk factor for visual deterioration in NF1 OPG, comparing a group of children who were observed only during follow-up with a group of children who were treated after an initial period of observation, and with another group of children who were treated up front at diagnosis, and we captured the visual acuity in this nice picture comparing these three populations. And basically what we found is that baseline visual impairment or the presence of 2 or more visual symptoms were possible risk factor for a further visual progression. So should be considered as kind of a criteria to consider starting treatment earlier rather than later. And the factors influencing treatment decision, specifically in NF1 OPG, have been kind of outlined in this nice review by the US team, highlighting how the visual progression is a clear criteria to start treatment. But beside this, there are multiple factors, including tumor involvement of the post-chiasmatic structure, progressive radiological growth, or unreliable visual assessment, as well as which might suggest that we should consider treatment. On the other side, the presence of a stable tumor and a stable visual function and a reliable visual assessment would suggest that we could possibly have an increased vigilance or a normal surveillance without needing to start treatment. Other factors not affecting decision to start treatment include precocious puberty, which needs a specific endocrine treatment but not necessarily an oncologic treatment, as well as severe proptosis in an already non-functioning eye. So who needs treatment already at diagnosis in the OPG group? We know that infants below 1 year of age are at higher risk for for progression, and most of them, they progress more than one time, and they have unfavorable visual outcome as well. So most of them, they will require treatment, and we advise to start treatment already at diagnosis without waiting for further progression. And the French groups has proven already many years ago in this seminal paper that age less than 1, coupled with a poor response to chemotherapy, represent the main 2 independent prognostic factor for progression. And this is true also when we look at the visual progression. Age less than 1 is still one of the main prognostic factor, together with poor response to chemotherapy. So now, what is the role of surgery in the management of OPG? So basically, it's not a surgical disease, so we do not recommend surgery, any surgical attempt in OPG. However, we don't know whether a partial debulking might favor a better progression-free survival by reducing the initial tumor bulk. But what are the costs of this debulking? We always need to consider the functional outcome in terms of vision, neurology, and endocrine and hypothalamic dysfunction. So most of the time, what we ask to our neurosurgical colleagues is to give us some tissue to get a diagnostic confirmation. And we heard from Rita how this has become more and more important. So we can learn the biology of this tumor and perhaps treat this tumor differently according to the biology. And severe proptotic eye in selected case might benefit from a surgical treatment. So still the mainstay of treatment in OPG is based on systemic chemotherapy. And we know from multiple trials that vincristine carboplatin have a kind of a reasonably good progression-free survival around the 45%. And this progression-free survival is clearly better for the NF1. You can see here around 70%. And this treatment is well manageable in terms of side effects, with very few, with no long-term side effects. However, we have very limited visual data on the efficacy of this regimen. Results of a couple of randomized trials in LGG have failed to prove any superiority of other regimen or better toxicity profile. So you can see the seminal US paper comparing vincristine carboplatin with TPCV, and despite the TPCV is slightly superior in terms of progression-free survival, the US recommendation is not to use TPCV as standard of care because the toxicity outweighed the benefit of this new regimen. And in the European study, when comparing children with vincristine carbo plus minus the addition of etoposide, we couldn't prove any benefit of the addition of etoposide in comparison with the standard of care. So now there is this interesting Canadian story about the use of vinblastine in a relapse or newly diagnosed LGG, and clearly they've shown there might be a non-inferior progression-free survival in the Canadian series with the use of a single agent vinblastine, which is of course highly attractive because it's easy to administer with very low toxicity profile, is very cheap, and can give for a longer period of time. However, there are very limited functional outcome, and this is mainly a single institution country. So interestingly, when the German group look at the German PSYOP LGG data and try to compare the progression-free survival at first relapse compared to further relapse, they clearly could see that there is no clear benefit of a vinblastine-based strategy compared to a platinum-based strategy. And what is even more interesting, if we split the groups between the non-NF1 group, between the NF1 group, which are the ones in the dot lines, we could clearly see that the vinblastine was significantly inferior to the platinum-based strategy in the non-NF1 group. While perhaps in the NF1 subset, the vinblastine is not inferior compared to other regimen. When we look at the data about visual outcome with the current chemotherapy, they are very limited and few. And the UK group has attempted to show the visual outcome with the current chemotherapy, and showing that basically 24% of the patients roughly have an improvement of visual outcome, and still the majority of the patients have a stable or a significant proportion, around 40%, still have a visual progression during time. And you can see here how the NF1 might have a more favorable visual outcome compared to the sporadic ones. Other possible treatment that you certainly know is the use of anti-angiogenetic factor like Bevacizumab, which has proven to be highly effective, at least in the short term, for a subset of children with multiply relapsed low-grade glioma and optic pathway glioma. However, the limit of the Bevacizumab is the limited durability and the risk of regrowth after treatment interruption, on top of the cost of this drug. We have currently done a preliminary analysis on the GOSH data set about visual outcome in patients treated with Bevacizumab, together with one of the great colleagues who spent some time here at GOSH. I want to thank, and showing that 60% of the eyes have some improvement, but 33% still relapse after treatment interruption. So now, in comparison with the standard chemotherapy, I think Rita has already pointed out that probably, despite the very limited data, but there are very interesting hopes that with a new era of molecular-based treatment, the visual outcome could really improve in this patient. Is there any role for radiotherapy in children with OPG? We know that radiotherapy is highly effective, perhaps more effective than chemotherapy in treating low-grade glioma. However, we need to take into account all the side effects on the long term, including neurocognitive side effects, endocrine side effects, as well as the risk of secondary malignancies, specifically for children with NF1. So currently, radiotherapy is not recommended as the first line of treatment. However, given the presence of the modern radiotherapy techniques, radiotherapy should still be considered, especially when the tumor progression risk an outcome which is worse than the radiotherapy-related outcome. So how to improve treatment, our current treatment management for children with OPG? So one possible aspect is to identify better risk factor for visual loss, and this nice paper have shown how radiologists can perhaps help either with the use of fractional anisotropy with diffuse tractography, or by the use of volumetric MRI, can both provide prognostic information which can predict the risk of visual outcome, as well as better understanding the biology of this tumor and realizing the different activated pathway in the context of non-NF1 or NF1 optic pathway glioma. And this has led to the two clinical trials that Rita has mentioned, which incorporates a use of molecularly targeted agent upfront in low-grade glioma, either with trametinib for sporadic one or selumetinib for the NF1 associated low-grade glioma. And we can see the phase 2 data from the selumetinib cohort in NF1 low-grade glioma, and how they lead to a very high rate of radiologic response. So now the use of molecular risk stratification, of course, can provide a new era for risk stratification. And we've seen how probably the BRAF V600E tumors are the worst group among the low-grade glioma, especially when they are associated with the CDKN2 deletion. And they represent here in this nice review a high-risk population, while on the other side, children with NF1, as well as those who carry the BRAF fusion, they might represent kind of a low-risk group according to the molecular stratification. Another possible point of improvement to better treat children with OPG is certainly to focus on visual quality of life outcomes. So move from a visual function, how the eye function, to understand the functional vision, so how the person function with this problem. And we know that with different levels of visual acuity, these may translate in normal or abnormal overall capabilities in a functioning of a patient. And we know that sight impairment can significantly affect the quality of life, as well as limiting the driving abilities of this patient or the ability to cope in school. So this functional outcome and quality of life outcome needs to be incorporated in the main primary outcome measure of the next generation clinical trial. Very interesting insights about how to better treat these patients come from the use and the phase 2 results of this small mono-institutional trial done in Rome a few years ago, using the discovery of the nerve growth factor from the famous Rita Levi-Montalcini Nobel Prize, and applying the nerve growth factor in an eye drop formulation, proving that some of these patients have a definitive improvement, at least in the visual fields, as well as some neurophysiological parameters. However, the limits of these studies are the cost and the production of the nerve growth factor, as well as the lack of data on visual acuity itself. Probably, if we better understand the development of optic glioma, we will learn better how to treat and perhaps when we should treat this patient. And we can see from this nice graph that there might be a window before the patient vision gets completely and ultimately irreversibly lost, when there is an anatomical change. And we shall perhaps study the mouse model, and there are some very nice mouse models which have shown that if you give some drugs like lovastatin, which apparently has nothing to do with the optic glioma, but interferes with the mechanism of OPG tumor growth, if you give this drug early during the development of the optic nerve glioma, you can normalize the retinal fibers and limits the apoptosis in the retinal fibers, improving the ultimate visual outcome of these children. So, in summary, children with OPG, when to treat and when not to treat. I'm not sure I have an answer, and an answer is not out there probably, but we have few take-home message, and mainly that one size does not fit all, and OPG is a heterogeneous disease. While we know that vincristine carbon is the first-line treatment, we need to accept that progression-free survival is still unsatisfactory, and we know very little about visual outcome. While many NF1 kids might not need treatment, at least at diagnosis, some children still need it because of visual progression. And there might be a possible role for vinblastine single agent in this subset of children. Infant less than 1 year old needs to be treated at diagnosis because they represent a high-risk group. And ongoing clinical trials using MEK inhibitors need to prove some superiority compared with the standard chemotherapy because of the cost of this drug and the lack of long-term data around side effects. Radiotherapy is rarely needed in OPG, but still some patients might need it, and we need to carefully consider and select this patient. There is room to optimize treatment while reducing the burden of disease, and possibly the use of antivascular endothelial growth factor as well as nerve growth factor eye drops, as well as other agents, might prove to be useful in the next coming future. And of course, using a more reliable and molecular-based risk stratification for OPG might also improve the overall outcome. Ultimately, we need to evaluate long-term functional outcome, including vision and visual-related quality of life in a standardized way. Now, going back to our treatment, to our case scenario, so after the primary physician decided to watch and wait initially, and after 6 months, the visual outcome deteriorated, and the tumor, you can clearly see on this slide how the tumor grew in 6 months of time. So I guess now perhaps the decision about starting treatment is more straightforward. And with this, I will thank you for your attention.